Welcome to today's Explainer. Okay, let's dive right into this. Today, we're taking a really fascinating journey. We're looking at a comparative medical pathway of two totally distinct but structurally related malignancies, cancers of the tongue and cancers of the cervix. Both of these are absolutely crucial conditions that pop up a lot in clinical practice. So what we're going to do is trace the journey of both diseases at the exact same time, literally from their origins all the way to their outcomes. Let's take a look at our roadmap.
So here's our pathway for today. We'll start with the introduction and epidemiology, then move right into causes and risk factors. After that, pathology and clinical presentation, diagnosing the cancers, management and complications, and finally, we'll wrap up with prognosis and prevention.
Starting off with Section 1, Introduction and Epidemiology. Basically, who gets these cancers and why?
To really get a firm grip on these diseases, we first have to understand the anatomy and the biology behind them. Both of these malignancies actually start in epithelial tissues, that's the lining of our organs, and they're predominantly squamous cell carcinomas. But, and this is a big but, their differing anatomy changes literally everything. Think about the tongue. It's this highly muscular organ, right? And its oral base has an incredibly rich lymphatic drainage system. Unfortunately, that rich drainage is exactly what facilitates early metastasis. Now, flip over to the cervix, which is the lower portion of the uterus. It features this really critical area called the transformation zone. This is the exact junction where the flat, protective squamous cells meet the taller, gland-like columnar cells. It's a highly active zone of cellular transition, and that is exactly where most cervical cancers develop.
Now, what's really interesting about this is the demographic contrast. It's stark. Tongue cancer primarily affects men over the age of 50, usually folks who've had chronic exposure to certain carcinogens over their lifetime. Cervical cancer, on the other hand, sees its peak incidence in women aged between 35 and 55, and it remains a massive cause of cancer mortality in developing countries. For example, we see really high prevalence in many parts of Nigeria, and that's heavily driven by limited access to screening programs.
Moving right along to Section 2, Causes and Risk Factors, the Triggers and Transformations.
Let's look at tongue cancer first. The risks here are heavily tied to lifestyle and chronic environmental exposures. The big culprits? Tobacco smoking, smokeless tobacco, and alcohol consumption. But we also see high rates linked to things like betel nut chewing, poor oral hygiene, and even chronic physical irritation. Think about having a sharp tooth or ill-fitting dentures just constantly rubbing against the inside of your mouth over years and years. In really sharp contrast, cervical cancer is primarily an infectious and reproductive-linked disease. The #1 leading risk factor is persistent infection with the human papillomavirus, or HPV, specifically those high-risk types, 16 and 18. Other contributing factors we look out for include early sexual activity, having multiple sexual partners, long-term oral contraceptive use, high parity, which just means having had multiple pregnancies, along with immunosuppression and smoking. So if we distill all this down to the core biological triggers, we see this fascinating divergence. With tongue cancer, it's really all about synergy. The synergistic effects of tobacco and alcohol combined just massively increase the risk of malignant transformation in the mouth. But for cervical cancer, the biological trigger is viral oncogenesis. It's that persistent HPV infection directly driving the transformation of those vulnerable cells right there in the cervical transformation zone. Okay, Section 3, Pathology and Clinical Presentation. Essentially, how this alters the body. Let's move to the cervical cancer sequence and see how this builds. It's a very clear step-by-step pathological process. It always starts with that initial HPV infection. From there, it progresses to a precancerous phase that we call cervical intraepithelial neoplasia, or CIN for short. If that's left unchecked, it advances to carcinoma in situ, and finally, it breaks through to become invasive cervical cancer. Once it's invasive, it can spread directly into the uterus and vagina or travel through the lymphatics.
Now, tongue cancer, which arises from that stratified squamous epithelium, is highly aggressive. Repeated exposure to carcinogens leads to dysplasia, then carcinoma in situ, and finally, invasive squamous cell carcinoma. And remember that really rich lymphatic supply we talked about earlier? Well, because of that, it spreads early to the submandibular and upper deep cervical lymph nodes. The tumor can literally just invade right into the intrinsic tongue muscles, the floor of the mouth, the mandible, and the oropharynx. It causes some incredibly devastating functional impairment as it progresses.
So, clinically speaking, what does a patient actually experience?
Well, for tongue cancer, it's often this persistent, hardened ulcer with raised margins, usually sitting right on the side of the tongue. Patients come in reporting pain, difficulty swallowing, speech issues, and, interestingly, referred ear pain. That happens because the tumor involves the glossopharyngeal nerve. Cervical cancer, conversely, can be totally asymptomatic in the early stages. You wouldn't even know it's there. When symptoms do finally appear, they usually show up as abnormal vaginal bleeding, bleeding after intercourse, bleeding between periods, or a foul-smelling vaginal discharge.
Let's shift gears to Section 4, Diagnosing the Cancers, Differential and Investigation. To get an accurate diagnosis, we obviously have to eliminate the mimics first. For the tongue, doctors have to rule out things like traumatic ulcers, oral leukoplakia, tuberculosis of the oral cavity, and even lesions from syphilis. For the cervix, the differential diagnosis list looks quite different. We're looking at ruling out cervical polyps, pelvic inflammatory disease, chronic cervicitis, and endometrial cancer. To actually confirm the diagnosis and stage the disease, clinicians use incredibly tailored investigative pathways. Let's break it down. For the tongue, the gold standard is an incisional or excisional biopsy to confirm if it's malignant. That's usually followed up by CT or MRI scans to figure out the tumor size, see if there's local invasion, and check for nodal metastases using the TNM staging system. Now, for the cervix, screening starts with the standard Pap test and HPV testing. If anything looks suspicious, they'll do a colposcopy, which allows for direct visualization and biopsy. And just like with the tongue, an MRI or CT is used later on to assess exactly how far the disease might have spread. So, that brings us to the big question. Once diagnosed, how do we actually stop the spread? That brings us to Section 5, Management and Complications, Fighting the Disease. Management is heavily stage dependent. For early tongue cancer, the primary treatment is surgical. We're talking about a partial glossectomy or hemiglossectomy, and that's often combined with a neck dissection to clear out the lymph nodes. For early cervical cancer, surgery looks like cervical conization or a simple or radical hysterectomy. But for both of these cancers, if the disease is locally advanced, the management strategy has to shift toward a multidisciplinary combination, usually relying heavily on radiotherapy and chemotherapy. So the crucial point here is that because of their completely distinct anatomical locations, these cancers cause drastically different complications. Tongue cancer complications are deeply functional. We see severe speech impairment, dysphagia, which leads to pretty severe nutritional deficiencies, and metastasis to the lungs. Advanced cervical cancer, on the other hand, presents a totally different nightmare of complications. This includes obstructive uropathy, severe anemia, and the formation of really devastating fistulas, abnormal connections between the bladder and vagina or the rectum and vagina.
And finally, Section 6, Prognosis and Prevention, Looking Forward.
The prognosis for both of these cancers hinges on one universal truth. Early detection is absolutely everything. The 5-year survival rate for tongue cancer is significantly higher if we catch it in the early stages, but it absolutely plummets once nodal metastasis occurs. It's a very similar story for cervical cancer. Early detection through routine screening significantly improves survival rates, whereas advanced disease carries a far poorer prognosis simply due to local invasion and distant metastasis. Because early detection is so critical, prevention really is our greatest weapon here. For tongue cancer, prevention is largely behavioral, right? It's about avoiding tobacco and alcohol, treating any pre-malignant lesions as soon as they appear, and doing regular oral exams for high-risk individuals. For cervical cancer, prevention is much more systemic and medical. It's about administering the HPV vaccine, ensuring regular cervical screening, and practicing safe sex. And you know what? That systemic approach actually works. As our source material brilliantly points out, vaccination programs targeting adolescents have significantly reduced the incidence of cervical cancer in many countries. It's amazing to see. Public health education and screening aren't just nice things to have, they are literal lifesavers.